everyone, welcome back to our channel. It's Veronica between two ferns and a candle. Today we're going to be looking at 7 atrial dysrhythmias. So I'm going to go ahead and begin with a sinus arrhythmia. And so this is typically irregular because it's not predictable. And the biggest thing to know with this is that it occurs with inspiration, expiration. So with inspiration, you're going to find that the heart rate speeds up. So on an EKG, you'll find that that rate is quicker, then it'll slow down, then it'll be quicker, then it'll be slow down. And the biggest thing as far as diagnosing this is just to watch your patient breathe and observe that while also observing the EKG. With this, it's not harmful, so no treatments needed. We're now going to go ahead and look at 6 sinus syndrome. And so if you have a patient who comes in and they are bradycardic and you cannot find any underlying cause, you've tried everything and nothing makes sense, this could be on your differential. And you can also find that you have a patient who's switching between brady and tachycardia as well. And so keep in mind that this is a syndrome, it's not a disease. And one thing, if you want to diagnose this, your patient has to come in with symptoms in order for diagnosis. It cannot just be an EKG finding. And the ultimate treatment is going to be a pacemaker. And now we're going to go ahead and move down to premature atrial contractions. And so it's all in the name, so premature early atrial contractions. And so we have a little EKG here. You see that there's normal, normal, and then you see very quickly you have that premature atrial contraction. So it occurs quickly. And you can find this just by using your little markers, measuring it out, and you'll just find that there's one that's kind of earlier than the other, and then it continues as normal. And so typically there's going to be no or few symptoms in these patients. And so if you want to do diagnoses, you can use an echo to look for any underlying diseases, but usually your patient's not going to come and complain of symptoms associated to this. And typically there's going to be asymptomatic, so you'll provide no treatment. Just reassurance, let them know everything's okay. If your patient's really concerned, they keep coming in with some type of problem associated to this, you can move on to beta blockers, and then the ultimate treatment would be ablation. So now we're going to go ahead and move on to some other ones, and we're going to have Shannon do that for us today.
So Veronica covered the first 3 out of 7 atrial dysrhythmias that exist, so I'm going to cover the last 4. So one that we're going to talk about is AFib. This is pretty common. Patients, AFib is definitely not uncommon. So the most important thing with AFib is that it is a irregularly irregular rhythm. So what this means, the first irregular is that it's not predictable, and the second irregular means that it is not equidistant. So not unpredictable, not equidistant rhythm. When you see an AFib on EKG, you can also, if you are listening to the patient, you can maybe hear like you could listen to the irregularly irregular, so it might be not beats, it's just maybe beat and then earlies. But when you see an EKG, you can either have fine or coarse fibrillations. So when I learned this, I thought initially you had to see the fibrillations, but don't be fooled by that. You can actually see AFib without any fibrillations on the EKG because it can have a really fine line, but you know that it's irregularly irregular, and so then you know it's AFib. So the treatment for this is going to be anticoagulate based upon the CHA2DS2-VASc score, and then decide between rate and rhythm control. Generally, we do rate control for people who are older and might not want to explore AFib options, or rhythm options, and then rhythm for people who are younger. And rhythm includes antiarrhythmic drugs like amio or flecainide. It also includes ablation, because you ablate and then hopefully that gets rid of the bad rhythm, and then also direct current cardioversion, so just cardioverting a patient. So our next rhythm that we're going to go to is a flutter. A flutter, the EKG pattern that we're looking for is sawtooth waves. So super board question, also if you ever see it, sawtooth waves tells you a flutter. And then what you want to do to determine the rhythm is count the number of waves between any QRS complex. So if you have 3 waves, kind of like this drawing, it's 3 to 1 a flutter, and then you can also have 2 to 1 and 1 to 1, and then 1 to 1 is the most deadly because every other beat is that flutter wave, so that's pretty harmful. So sawtooth waves, and the treatment is going to be the exact same as AFib. Moving on, we have WAP and MAT. So WAP is wandering atrial pacemaker, and MAT is multifocal atrial tachy. The definition for WAP and MAT is that you have 3+ weird, morphologically weird P waves. So if you see P waves that are very inconsistent, and you see 3+ in a 12-lead EKG, that is WAP. If it's less than 100 beats per minute. And then if you see the 3+ weird P waves and it's greater than 100 beats per minute, then that is MAT. One thing to know is that MAT is associated with COPD. So you can remember this, that MAT is really fast, greater than 100 beats per minute, in whatever way you want to remember that MAT is fast, and MAT has COPD. So those three kind of go together. So our last one that we're going to go over atrial dysrhythmia is supraventricular tachycardia. So supraventricular tachycardia, this sometimes can be difficult to discern between just normal tachycardia, but the one thing to know is that it has a very sudden onset. So if the patient is normal sinus rhythm and then boom, in the middle of EKG it gets really fast, that's how you know it's supraventricular tachycardia. It's also called sometimes paroxysmal SVT, so know that those are synonymous. So the treatment for this, there's a couple different kinds, but the first thing generally a nurse is going to have, or a provider, have the patient blow into a straw to vagal down. So hopefully just slowing down the heart rate is going to get them out of the rhythm. If not, we're going to do adenosine. Adenosine is a vasodilator, also works to restart the heart a little bit. So hopefully we vasodilate and that lowers their blood pressure and heart rate and that gets them out of the rhythm. And then if not, we can do a non-DHP calcium channel blocker. So I like to remember a non-DHP is for SVT. So that would be diltiazem or verapamil. And then if you can't get the patient out of supraventricular tachy or they keep going into it, the definitive management is ablation. So thank you for tuning in. Follow us when we cover ventricular dysrhythmias.